Welcome, everybody. Thank you for coming to our March webinar for the Computational Social Sciences of America, the Society. And so what I like to say is that we've got some great speakers today. This is the award winners from the ESSA conference. Our president, Kyle, was keen on us getting to see your work as well. Hence the reaching out. So thank you, Jason and Brian. And they are coming from us from the University of Melbourne. I will not do any further introductions because I'll let you introduce yourself and the topic. So thank you both. Over to you.
Thanks so much. Thanks for the invitation, Andrew, Kyle, Tim, the rest of the people that I can see here. My name is Jason Thompson. I'm Professor of Mental Health Systems Reform here at the University of Melbourne, where it's currently 1 a.m. So it's a great time to be joining everyone. I have a special affection for the Computational Social Science Society of the Americas, given that it was the first sort of computational social science society I was involved with back in or sort of attended conferences back in 20 I think 17 was the first one I went to. So when I was first getting into this field, so a real special affection for the association. Brenna, I might get you to start sharing the slides if that's okay. Well, as Andrew said, this work is really going to be focusing on an area of research that we have been pursuing for about the last decade, which is associated with application of models to real-world systems and insurance systems. So, are we able to share those slides?
Sorry, coming.
Yeah, no, you're right.
All right.
So, for about the work that we first got involved with was in traffic simulation models. So the work that we used to do back in sort of the early teens was around traffic simulation models and safety. First of all, it was around about traffic safety, which was sort of a natural thing. So we're looking at safety in the Victorian transport system, but then we're also working with insurance systems. So not only we're looking at traffic safety, but looking at the way in which people move through the insurance systems, which were rehabilitation systems associated with traffic injury. So we were moving from, I suppose, a more of a concrete representation of a transport system through to a much more abstract system of trying to model an insurance system or a healthcare system. And that's really where we've gone over the last decade is to try to use social simulation and agent-based modeling to represent different areas of social insurance, rehabilitation systems, injury rehabilitation, disability rehabilitation, and the way in which people interact with those systems. And the whole idea is around policy modeling. So maybe we can just skip through to the next slide, Brennan. So if you look at one back, sorry, Brenna. So if you look at really the sorts of things that we're interested in insurance systems, we're interested in road safety, we're interested in workplace safety, we're interested in disability, we're interested in how all these sort of things come together, and we're interested in the performance of those systems and creating high performance systems. So next slide. And when we talk about the performance of systems, we really, I'm a frameworks person, so have to try to understand the world through various frameworks. And one of the main frameworks that we use for understanding high performance in health systems and the outcomes is this Murray and Frank framework, which is really about three elements of: does the health system as it's designed improve the health of people, so improve health outcomes? Does it improve health outcomes by also is it a reasonable experience for people? So you might improve health outcomes, but it's a terrible experience and they do it really poorly. So are people generally satisfied with the healthcare system or the insurance system that they deal with? And the last thing is fair financing. So does the system survive? So you could make everyone very, very happy about the system that they're involved with. You could help increase health outcomes greatly, but if the entire system collapses because it's unable to survive financially, then that's not really useful either. So just next slide. So this, as all good frameworks do, this three-element framework has been expanded recently to five, which I'm happy to deal with 5 elements. If it gets too much bigger, I might have to abandon it. But so adding on to the 3 elements of outcomes, the experience of people in the healthcare system, and fair financing, they've also added equity and access to that system and the health of the workforce, because if you don't look after the workforce, that is also an unsustainable system. So we try to think about the performance of the healthcare systems that we simulate in terms of these outcomes, which generally, if you look at the annual reports of organisations, etc., they all tend to coalesce around these areas, whether they mean to formally or not. So these are the sorts of areas that we're interested in. So next slide, Brenna. And in modeling these insurance systems, we tend to look at their what we might describe as their classic moves. So generally, they will try to intervene early in people's outcomes. So identifying risk people who are at risk of poor outcomes, they'll try to prevent something before it starts. So road safety is a classic example. They'll try to improve access to services. So the services might be latent and they mightn't be available because people think it's too burdensome to deal with an insurance system. So they'll try to fix that aspect. They'll try to improve internal processes. They might just do nothing. On the other side, they might try to increase barriers to access. So they might sort of say, okay, well, these people aren't eligible for insurance anymore because they're essentially costing us too much money. So we just exclude people. Where they might pre-approve access to services to increase or to decrease the administrative burden of the services. They might invest in improving the quality of existing services, so to train people up in certain elements of rehabilitation or care to make sure that it's targeted towards the population that they're serving, or they might reduce eligibility or sort of kick people out of a scheme or insurance scheme or something earlier, something like that, in order to reduce their client cohort. And so the last thing I wanted to say, which is the next slide, was really where the models and some of the work that you're about to hear from Branislava is an example of that, where we're trying to model these systems for the system operators. So we try to build immersive, interactive, large scale, or small to large scale policy simulation, experimentation, and performance optimization opportunities where we have the decision makers within those systems actually interact with schemes, which at the start to them feel very much like toys, but after they've been interacting with them for some time, they suddenly become very serious, and they demonstrate much of the complexity that the real systems do. So I'm going to hand over to Branislava here to walk you through the work that she's been doing. But I just wanted to give you an introduction to the sorts of work that we've been doing, and really, thank the society too for encouraging this work. It's around a decade ago, and this is the pathway we've been on. So I just want to emphasise the importance of society and in encouraging this vein of work over the last decade. So over to Brenna.
Thank you, and apologies for the technical difficulties. I'm going to blame that on it being 1 a.m. But thanks, Chase. So thank you everyone for joining. Again, apologies, it is 1 o'clock in the morning, so I'm going to try and sound as coherent as I can. But my name is Branna, and today I will be talking to you about a project that we've been conducting over the past few years, in the same vein of work that Jace was talking about, but specifically in the realm of workers' compensation systems. And the agent-based model in particular that we've been building to apply to a generic workers' compensation system in Australia, and basing this on ideas from injured workers. So in Australia, at least, roughly 500,000 Australians every year will experience a workplace injury. And some of these workplace injuries will only be minor, so bumps and bruises and things that only need a little report and don't require time off work. But unfortunately, some injured workers need a lot more support due to a much more significant injury or illness that requires time off work and requires more significant intervention. Workers' compensation is a type of social insurance that can help them with this, and it can provide them with financial benefits, medical treatments, domestic support if needed, and sometimes return to work services, depending on how long they've had off work. And the purpose of these schemes is to try and help injured workers at the time that they are particularly vulnerable and they really do need it the most. But the question that arises with all systems, I guess, is do they actually manage to achieve this? And the evidence on this is mixed. So in some cases, people have great experiences with workers' compensation. So sometimes people have, particularly if often people who are male have had traumatic or musculoskeletal injuries or similar conditions, have reported really positive scheme experiences and were more likely to return to work. But unfortunately, these positive experiences are not the case for everyone. So in some cases, people found dealing with workers' compensation systems incredibly stressful. They found that they had negative financial and employment-related consequences and significantly impacted their quality of life, personal relationships, delayed their recovery, and even in some cases caused secondary psychological injury, which is a psychological condition that emerges after having to interact with the schemes or is caused by interaction with the schemes. So they can cause significant psychological distress. And so what our project is aimed to do was to try and redesign workers' compensation systems using modelling methods based on the experiences of people who have been through the systems. And so the first part of our study aimed to really focus on understanding the perspectives of injured workers who have been through the schemes. There's an extensive literature on this already, but we wanted to speak to them to begin with to understand their perspectives, but also to gain some ideas about how they might envision that workers' compensation systems could work from their perspective based on what they've been through. And so one of our colleagues conducted interviews, surveys, and focus groups with injured workers and representatives to try and understand as best we could. And this is the perspective that most people put forward in a schematic. So people often felt like they were dealing with a maze. And as a fun fact, if you think of Franz Kafka, I think, if I'm not mistaken, actually worked in workers' compensation systems. So if you think about Kafkaesque systems, that's what we're talking about. And so the next few slides, I'm going to show you some of the quotes that came through when we spoke to injured workers. And some of these I think are particularly compelling. So people describe the system as impacting their entire lives, or their entire lives feeling completely screwed. They said that if you're not in it, you don't understand. People don't understand what it does to people's heads and the isolation and complex trauma that it causes. People described feeling particularly broken in many different ways, physically, mentally, and emotionally. They found it very confusing. They found it difficult to navigate as no one said what actually happens. Feelings of powerlessness, and some people described being warned about how bad the system is and found that they were right in hindsight. And so the system design has often not accounted for the perspectives of these injured workers. So understandably, they're often designed by governments, regulatory bodies, and stakeholders who have the relevant expertise, which makes complete sense. But what our project wanted to contribute, as I mentioned earlier, is to try and use some of the ideas from injured workers to look at how things might look if we change things from their perspectives. But in order to do that, what we started with is building 2 models. So one of them was a system dynamics model that I won't be focusing as much on today, to give us a high-level overview of the scheme, and then also an agent-based model. So to develop these current state schemes upon which we could then test and explore and experiment with different policies. And so, as Jace mentioned earlier, the insurance schemes, when we are considering a recreation of them, we also have to recognise that they do have constraints within which they must operate. So they have to be financially responsible, maintain client satisfaction, and basically also ensure that people do get better. So people have to have a good experience, ideally, with the scheme in which they can recover, and the scheme overall is financially sustainable. And so, as I mentioned, the attempts at reforming the scheme must be able to appreciate all of this at the individual and scheme level, which is what these methods have allowed us to do. So our first model that aimed to recreate the current state was the system dynamics model that I mentioned briefly. This allowed us to present a high-level overview of the entire scheme. And the way that we developed this was using insurer and regulator resources that were publicly available. So just scouring websites, as many policy documents as we could, that kind of thing. Academic literature, of course, and then speaking to a lot of domain experts who have worked in and around many different elements of the scheme. So from the legal perspective to people who have worked in the schemes or researched the schemes for many, many years. And then we also had a group of lived experience advisors who also worked with us as well. And so again, in brief, this is our system dynamics model. So this is the schematic that we show people. And often one of the first responses that we get is, no wonder people are so confused, because navigating a scheme like this when you don't know what you're getting yourself into is overwhelming. And it's completely understandable that people feel a certain way when they're trying to navigate these schemes. And so this system dynamics model allows us to explore different high-level policies across the entire scheme. And again, I won't be focusing on it in too much detail, but I'm happy to take questions on it. But this allowed us to have an understanding of the entire scheme from which we could then build an individual representation using the agent-based model, which is basically just what I've said on this slide. So I will work it through. I will skip the first bit of it. But what the ABM has allowed us to do is to mostly focus on the early stages of someone's experience with the workers' compensation scheme. So in particular, the worker's injury, the process of submitting a claim, having a claim assessed, and receiving services. And it's now been built out to include some of the processes through which people might be requested to leave the scheme as well. And so for the next bit, I will apologise for the simplicity of it. There's many more icons than I'm usually comfortable with in any sort of presentation, but I will walk you through a very simple representation of some of the interactions and agents within our model. So what we start out with are injured workers. These injured workers have characteristics, including age, gender, and injury type. And these injured workers will then often go and see a GP. Upon seeing a GP, the GP will assess their injury. They'll determine whether they will assess whether they would like to provide support for it or not. And if the general practitioner does provide support for it, the injured worker is then permitted to submit a claim. Otherwise, they are not. Once the claim has been submitted, it then goes to claims managers. Claims managers have their own characteristics, including the different specialisation that they might have. So in some cases, claims managers only work with the claims processing side of things, which is the initial claim assessment. Whereas in other cases, claims managers focus on what we term service provision, which is when service requests are submitted by people. So for example, for medical treatments, they will assess the request and decide whether it needs further investigation or whether it gets approved or denied. But in the first case, the claims processing claims managers will have a look at the claim. They'll have a look at a number of different factors about the claim, including the injury type. So we have 4 categories that we consider, including diseases, musculoskeletal conditions, physical injuries, and psychological conditions. The claims managers often have a particular temperament as well. They will have an ongoing workload that they would consider, and they would also consider different elements of complexity about the claim. So including whether, for example, some conditions get assessed differently to other conditions. And they would also consider whether an injured worker requires additional support. Based on all of these elements, the claims manager then approves the claim or denies the claim. And ideally, once the claim has been approved, claims are categorized into either receiving financial and medical services, so people can receive income support in addition to medical services and access to similar services. But in some cases, if a claim isn't particularly severe and someone doesn't need a lot of time off, they can request to only receive medical services. But ideally, in both cases, you would expect or hope that someone's progress and recovery improves after having access to the level of support that they need. However, as we know, things are never quite that simple, and there can be numerous sources of complexity that can exist throughout the model. And these can come from delays. So a lot of the time, as I mentioned, the claims managers can have their own backlog and their own task list. Based on their level of experience as well, we can also determine how much capacity someone has. And if someone is over capacity, this can cause delays in processing requests. There can be a lack of clarity as well. So sometimes people won't be able to access certain things and they might not know why. And like I mentioned, difficulties with access. So even in some cases, for example, the general practitioners can be a source of limited access, where not all of the general practitioners will necessarily want to work with workers' compensation claims, which is something that we know from the literature, because they can be an additional burden in terms of the administration required around working with workers' compensation schemes. So that's another aspect that we've included in the model as well. And so in terms of our analysis, we've done our analysis in a couple of different ways. So the first one is through the story of the agent. So this is one of the ways that originally came out as a bug checking mechanism, but then we found that it had more value than we expected. And so we can track at each step different aspects about each agent, so including their claim status, so whether the claim has been approved or not, the claim type, so as I mentioned, whether people are receiving only medical services or income support as well. The number of requests that they've submitted, their current work capacity, their current mental health score, their happiness with the scheme, and how long they've spent on the scheme in total. And so we can produce results like this, not this specifically, because this was generated with a large language model, but this is the kind of story that we can capture as we look at the printout of those results. So we can look at the way that a client came into the scheme and the condition that they had. So in this case, for example, someone came into the scheme with a particularly poor condition. Their work capacity was 2.6, which is quite low. But over time, they were able to receive services and slowly increased their work capacity. By day 278, they'd received 28 medical services and climbed to a 64 work capacity, which is great. And their satisfaction with the scheme hovered at around a 65, which isn't terrible. Their mental health in the case of this person was apparently pretty good, but the progress depended on the backlogs being cleared and being able to get their request looked at and assessed and approved ideally. So the other things that we can also look at are the number of approved claims in terms of the entire scheme. We can also look at average mental health and work capacity, claim processing times, average client satisfaction across the scheme, approved and denied service requests, unfulfilled service requests, and service request timers. So how long certain requests are taken to be approved or not. And these are some of the results that I'll take you through now. So the baseline results, when we run the model in a way that has values that we consider to be relatively reflective of a stable situation, we get the following outcomes. And what we're looking at here is a survival curve of how long certain people with certain injury types. So in the purple, we've got psychological injuries, in the red, physical injuries, in the green, musculoskeletal conditions, and in the blue, people with diseases, so including cancer and similar. And what we see here is that in this case, or in baseline scenarios, people with psychological injuries tend to stay on the scheme the longest, which is what we see reflected in the real world. And then followed by physical injuries, people with disease conditions, and musculoskeletal conditions. And this is similar to some data that we see from the real world, where people with psychological conditions do tend to stay on the scheme the longest. So it's another survival curve, followed by people with other types of injuries, musculoskeletal conditions and diseases as well. So this is telling us that at the moment in our baseline scenarios, our results are matching up fairly well to real world data. Unfortunately, I can't reveal the source of this real world data, but it is real world data. So what we can also do then is test different policies that would be of interest to insurers, because we are still developing the ideas that are coming from the injured workers. So I don't have those results at the moment, but I do have typical results that typical policies that insurers would look at. So some of the ones that Jason mentioned earlier, including changes to claim approval and denial rates. So something that schemes might do if they're looking to change their financial position, for example, would be to potentially alter the approval and denial rates throughout the schemes. They might look at staff capacity, so increasing, or I doubt they would decrease staff capacity, but or primarily just changing staff capacity. But then also another thing that they could do is change the definition of when someone is considered recovered. So for example, they could look at someone as recovered if they're sitting at an 80 in one case, but what happens if they start seeing recovery as defined at someone, if you're sort of 30%, or not 30%, but if you have a work capacity of about 30, are you good to go? So if you're considered good to go, then you would be exited from the scheme and considered as no longer needing support. So these are some of the results that I'll show you now. So in the first policy scenario, where we have changes to overall approval and denial rates, these are the sorts of curves that we observe. And so these are the results of sensitivity analyses that we're doing. And what we're looking at here are the differences to mean client satisfaction over time, over 1,000 steps in the model. And so what we've got are the different curves reflect the different baseline injury approval rates. And so what that means is that is the baseline from which claims managers start when they're looking to assess anything. So whether they're looking to assess a claim coming into the scheme, whether they're looking to assess a service that is being requested by someone. And so if the baseline is 0, things get quite messy because people don't really sort of know what to expect. But then we see a fairly steady sort of increase that as approval rates increase, what we then see is that people's clients' average satisfaction with the scheme increases as well, which is encouraging and also fairly intuitive. In the second policy, the second example that I'll show you is the changes to staff capacity. So what we have here is similarly results from sensitivity analyses that as the service provision claims managers, so these are the ones that only assess treatment requests and similar, as their service request capacity increases, so from 10 to 50, what we see here is a decrease in the average processing time or time to receive a decision about a request. So when someone's processing capacity is particularly low on average, then it takes longer to receive a decision about a medical service request. Whereas when it's higher and they have more capacity, decisions are made faster. And this is then also reflected in the client's work capacity, where, for example, if the service provision claims manager has a higher capacity, the clients also on average have a higher work capacity as well, because people are able to access medical services, access treatments, and recover as well, which is, again, intuitive compared to when they don't, and there is much lower work capacity and there is much lower capacity in terms of what the staff are capable of doing, then that's also reflected in clients' recovery as well. And another case is in terms of the changes to the return to work definition, so the point at which someone is considered recovered. The amount of time that someone would spend on the scheme if the maximum work capacity was 10 or 20 is on average much lower than if it's higher. So what this is reflecting is that if people are basically kicked off the scheme quicker if you're considered recovered sooner, and that is what we're seeing reflected here. And so those are the results that I'll show you briefly. Again, that was just a selection of a large pool of results, but this is just to give you an indication of the kinds of things that our model can explore. But something that we found is that a common critique of modelling is that we can often be considered to be impersonal or treat people as statistics. But in one of the workshops that I was doing with our lived experience advisors, we just received this bit of feedback that I thought would be nice to share, which is that one of our lived experience advisors found that this model covered, or one of our system dynamics model in particular, was able to capture part of the OH&S requirements, workers' compensation requirements, employment law, and human rights as well, was all encompassed in the model, which felt very nice to hear. You can't get a better model than that. Was very encouraging. I feel like she was being quite nice there, but still a nice bit of feedback to receive. And these are some of the takeaways. So the model has allowed us to capture the current state of the workers' compensation system because it's matching up quite nicely to real world data, which is great. It has been co-designed and developed with people with lived experience of workers' compensation processes, and we're still in the process of implementing ideas for alternative system designs to continue to evaluate them across the metrics that we mentioned, so claims liabilities, health outcomes, and satisfaction with the system. Thank you. Do I stop sharing now, or do I keep sharing?
Yeah, thank you very much. So yeah, please go ahead and stop sharing if you like. The way this works now, if it's okay with you both, is that we're going to open it up for questions from the audience, just to ask them, anything in particular. Usually you're going to get a mixed bag of questions, and usually they're quite good. So, okay. Not trying to oversell our group here, but so first of all, thank you very much for the talk. I really appreciate it. I'm actually, for once, not going to take advantage of my position as the host, and I will actually open up directly to the audience to see if they've got a question. Otherwise, if they don't, I will jump in.
I think there was one in the chat.
Yeah, it says, Nicholas has raised a hand. Nicholas, can you just speak up and ask your question?
Sure. I can also defer to Milton first because his question was in there first.
I can ask. I've just seen it. No, you go ahead, and then I'll read it and.
Okay. Well, Brani, thanks for the talk. That was super interesting. And actually, this is my first meeting of the group, so I'm just to introduce myself. I'm also a ABM modeler, mostly on climate adaptation. But I really enjoyed hearing about ABMs in a different setting. And I guess my question, just because I'm thinking about it in terms of climate insurance schemes, is whether in either the system dynamics model or the ABM, if you have incorporated any adaptive behavior like endogenously in the model on the part of the insurer or on the part of the government scheme that would take care of workers' compensation. And if so, like, what have been some strategies that you think or have been emerging in terms of that adaptive behavior on their end?
In terms of the adaptive behavior from the perspective of the insurer on a large scale, I'm going to say no at this stage. So we've only, particularly in the ABM, we've really just been focusing on the interpersonal dynamics. So we do have some kind of quite simple mechanisms of reflecting kind of tit for tat behavior or that kind of thing that can emerge. And I think the only other one that I would say is really emerging is in terms of adaptive behavior is what can happen when clients, we have an option that can be sort of switched on and off of whether people learn from each other. For example, so if a claimant then looks at someone has had a claim denied, for example, or has had a service request denied in particular, they can then look at someone else and go, why is yours getting approved and why is mine not getting approved? But we don't have options in the model at the moment as to, for example, if if say wait times are getting too long and then the scheme sort of adapts to that or responds to that. We don't have that in the model at the moment, but it would be a cool thing to include.
I might just step in there just to answer in for other models as well. In a previous model, we enabled the system to sort of adjust its policies in relation to like performance objectives, and obviously they're trading off these objectives all the time. We ended up in one scenario with an insurance system that was a bit like the classic sort of hospital with no patients. So what it would do is it performed very well, like in terms of all its metrics. It pretty much stopped as many people coming in as possible. But when they did come in, it just threw all its resources at everyone as soon as it could to get them out the door as fast as possible. So it was all about stopping people coming in. And when they did come in, okay, well, now that we have to deal with you, we're just going to throw all of our resources at you. So it is interesting watching, when you do build in some ability for the system to adjust based on feedback, how it ends up performing and how it optimizes.
Yeah, that's super interesting. I mean, I know the complexities of that, just trying to think about it in my own application. But the reason I thought about it, I think it was super striking how both in your model and in the real world data, how much people who come in with kind of mental health issues are kind of persisting in that system, whereas everybody else is. And obviously that might underlie like just different drivers, right, of those different conditions. But I wonder if over time, if you would expect to see the system kind of adapting how it's treating kind of those patients versus others.
In the real world, what they're doing is, so we talk about these sort of insurance system classic moves. What they're doing is just really stopping eligibility. So they don't know what to do with it in the real world, so they just turn the tap off essentially. So say, okay, well, this group of people is no longer eligible for our scheme, or you have to go and find help somewhere else. And we do have another model which is about the cascading effects of that as well, and really sort of showing, okay, well, people they're forced to leave this system, and really it just puts pressure on a downstream system down here.
Milton, I've noticed you've got a couple of questions. Do you want to just ask them directly, or would you prefer me to ask them from the chat?
No, I'm happy to ask them. I wasn't sure if there'd be a flurry of questions or what. I just thought I'd put it in there while I had the question in my head before I forgot. So
absolutely. So go back to back if you don't mind.
Okay. Well, the second one's more of a context question of developing models using Replit. I've been working in that space and kind of interested if that's a bit of a margin. We can just put that to the side. But the means of producing models, and I think that's a very interesting question, especially in a policy setting where you have to communicate with people who may not be into building models and things. Figuring out ways to use modeling to communicate and show people, the consequences of decisions, at least to help them think about those. So, but my question is a bit more of the baseline with your model of saying you're looking at in-system metrics and improvements and tweaks. That's great. But it would be interesting also to know, especially with agent-based models, because you can do all kinds of extreme cases to try to figure it out. Like, what if there is no there's no safety net? There is no, in other words, what happens at the very bottom if you don't have any of these helps? I'm just thinking of things like iatrogenics, where a system made to make you healthy makes you sick, and it's supposed to educate and it doesn't. What does the absence look like? I suppose your model would have to have a kind of baseline that there's some broader social capacity to take care of people. So, because we know there are individual cases where sometimes people are better off not being in the system and relying on informal support. So I'll just put that. I don't know the parameters on your model, how far it can be bent or pushed or tested, but I would be interested in that. And my context is working now in a corporate setting where we have cases of, staff members, employees who are on all of these leaves and watching them go in and out of the system and trying to help them navigate. And it's very practical. But anyway, that's my question, is just about the baseline. Like, what does it look like? How far can your model be pushed? So.
No, it's a really great question. It kind of reminds me of a similar one that I received at ESSA, where it was kind of the flip side to what you're asking, but I was asked about the prevention side of things, so stopping people from, going into the schemes at all if there were, all of the OH&S checks kind of worked, and, motivating further motivations and incentives around stopping people from entering the schemes at all. To answer your question, I think the focus of the model was really just to try and focus on people's experiences in the scheme. That's why we haven't compared it to a baseline where the scheme doesn't exist. So that's why that baseline isn't in there. But that's not to say that that isn't something that it hasn't come up necessarily, but it was something that came up in the system dynamics model, where particularly with interactions with GPs or general practitioners, for example, people would be advised against, in some cases, going towards workers' compensation, and that would often be higher for people with psychological injuries. And so this is still a model that's being validated at the moment, or verified at the moment, but that was something that we discussed, so that some people are steered away from, going into these schemes, because it honestly might be the best situation for them. But yeah, in short answer to your question, not with this particular model, but that's not to say that it couldn't be developed.
If I can just add in there too, so we do have another system dynamics model which has all of these. It's just stepping back a level where all of the different schemes exist, and we can turn people off just going to that scheme and sort of say, okay, well, disability support pension doesn't exist anymore, or workers' compensation doesn't exist anymore, or psychological injuries for workers' compensation doesn't exist anymore, and showing where they end up in a broader health system. I think and we did this for the superannuation industry a couple of weeks ago, sort of saying, so in Australia we have the superannuation industry, which is I suppose like your pension industry, and they have often, when you have superannuation, you have total and permanent disability insurance built into that as well. And so this, like all good insurers, they want to sell you a product, but they don't want you to claim on it. And so what was happening in workers' compensation was people were turning off the tap for people with psychological injuries to come into those schemes. And suddenly these superannuation funds were like, why do we have all these people who are making claims on our insurance system? They're not, we don't want people coming into the system. What's happening? And really, it was that flow through from that system not existing for a big cohort of people, and now it's flowing into another part of that system. So, and as academics, we're fortunate in that we are able to look at an entire system, but because they are all individual systems operating on themselves, when someone leaves their system, they don't care where they go, really. They just know that they're gone. And so that's sort of lost to them. But the iatrogenics element is that you mentioned there, Milton, is exactly why I got into this area. Most of the systems that we're talking about here are state-based systems, or they're supported by our state governments, and so they need a social license to operate. And so when they don't perform and performance across those criteria that we were talking about before, they don't get good outcomes. People hate dealing with them. They don't actually get good outcomes for the premium payers, like businesses who are putting money into them. Then the questions are asked, and they're in the newspapers, etc. So they and the iatrogenics too was sort of the basis of my own PhD, a long time ago, which was about who do you blame in your injury, and how does that affect your pathway through the insurance system. Also, happy to mention I often get accused of being a representative for Replit. I'm not, but I think Replit is very, very useful for helping people interact with agent-based models and getting process flows up and running, not for building the models themselves, but often some of the preparatory work and the interaction work for showing people results, and creating hypercubes, etc., of results, so that you can show people what's coming out of the models.
All of those graphs were built in Replit, the ones that I showed. So there was a way of, but we basically built an app that allowed us to extract everything that we needed to from the NetLogo outputs and then represent it in a way with the survival curves and all that sort of thing. And so, yeah, it's brilliant.
One of the things I found with Replit is it doesn't. I asked it to replicate NetLogo, so I just kind of went and say I want to build my own platform.
I won't do that. Yeah.
It can. It's months. It'll cost you. You may as well sell a kidney to get it done. But what it's good at is specific models. If you take, it'll actually produce it. Like you can actually produce a specific model, and so in that sense. And it kind of puts it a little bit closer to, putting it into other formats, digesting different information that are in some ways with NetLogo at times can be a little awkward to use. I find Replit's got its power can kind of be applied to a single model and really pushed in some interesting ways. So thank you. Good to hear. I'm in a setting where I find very few Replit users as well, like it's that are using it in significant ways, and yet I think for these kinds of like exploratory work like this, or you want to push it, you need a quick kind of check in on something. It's proven to be quite useful. So yeah, it's good to hear there's other users in the academic circles as well. So
yeah.
Thank you. So I'm going to abuse my position as the host here because I want to ask a question that I do think sort of follows on. So one thing I'm interested in is that I believe that individuals that are involved in a system, their behavior changes as that system increases in scale, right, or even in density. So looking at the system there, there's the complexity that you've shown, and obviously you're dealing with, 500,000 workers a year or something like this. I mean, at what point do you see that, how many can it handle, or would this, the way you're representing the system, if you scaled it down, would it be more efficient? Do you expect to see different behavior changes within the individual agents, especially the people that are making the claims, but also, more importantly, the people actually processing the claims as well?
I think, yeah. Well, we definitely see beyond a certain point. I mean, you have the results that you would expect to see. So there are massive delays, there are massive backlogs, all that sort of thing, especially because with some of the claims, with the way that they get investigated, and particularly for certain injury types, there's more investigations. And so it's not like those processes stop as well all of a sudden just because there are backlogs and delays. And so that causes further backlogs and delays, and that just sort of amplifies as things happen. But in terms of the kind of adaptive responses that happen to that, there's not much, but again, just because of the way that the model has been built, but it does happen. The system can cope quite well until a point, and then beyond that, it's just everything skyrockets, and things that you would expect to plummet absolutely plummet. So worker outcomes, scheme satisfaction, all that kind of thing, all of that just plummets in the way that you would expect it to.
So one of the suggestions that has been made is that it's about breaking these down into regions, right? I mean, I don't know if that's something that's come up where you are in Australia, and if you can talk about that. Therefore, have more regionalized individual systems that don't necessarily interact.
Yeah, so the model that we're trying to build, so all of these models are state-based. So as Jason mentioned earlier, so they are, unless I'm sort of misunderstanding your question, the way that we were trying to get around that is because we knew that when we were going to present these findings to regulators, because we've only got a handful of states to present them to, we knew that the regulators would come back and say, okay, this isn't represented here, or that element isn't represented there. So what we were trying to do is deliberately make a generic model that if you did tweak it in a few certain ways, you probably could get quite close to representing a particular state, if not in the ABM, particularly in the system dynamics model. So we could, so that was why, oh, you're right. Okay. Particularly in the system dynamics model, you could get quite close to approximating certain states and regions, but we went for a generic approach deliberately.
Okay, thank you. I'm sorry, that's my punishment for abusing my position. So, sorry, thank you. Okay. Please, someone else jump in.
I've got one if I can. So a frustration I've had building big policy models is that in the course of building it, I learn a huge amount. I end up with this super rich understanding in my head. I think I know a lot. Of course, there's a lot I don't know because I'm not really invested in the thing. But it's very hard to transfer that rich mental model that I've developed to the audience. You know, I get an hour or two to brief them, and they maybe not buy what I did. They suggest some changes. I do them. They maybe believe that I did them right. Maybe they think they notice they could have been done different ways. However, if you can get the luxury of having them work with you and they become invested, if they really get to actually work through the model, then they get all the benefit of the building. And I just wonder, what's your experience in trying to transfer? You know, you can build this really cool, sophisticated model and nobody cares. And I hate that. And it drives me crazy that that happens to me. How do you, is this resonating at all? How's that going?
I think I might hand this one over to Jason, to be honest.
Yeah. So this is so I wasn't always in academia. I was in one of these systems. So I used to work in there. So I had the luxury of co-designing, co-building models with the system operators, like for a long time. And we're variously successful in sort of doing it with them, doing it outside them, bringing it back to them, all this sort of stuff. And at various times we get different levels of traction. I mean, ideally, you're building it, you're co-designing it, you're building it with them so that they understand it as they go along. I suppose one of the just a anecdote about that, we about 8 years ago, we built a model, co-designed it with the organization. They loved the model. I think I showed a picture before of them sort of interacting with the model. It was sort of old NetLogo stuff, so it looked like Atari, and they didn't really know what to do with it. But then once they got into it, they sort of realized they had all this richness and this complexity. I'd get, okay, well, we would have these groups where I'd say, okay, you people over here, you managers, you're in charge of the finances, you guys are in charge of the outcomes, and you guys are in charge of the experience. Make them make serial sort of decisions about the way the model ran. The next group had to deal with the outcomes of that. It was very rich, and people got very passionate about it, and it wasn't a toy very quickly. Then there was a big decision that they were going to make about how they were actually changing the scheme in the real world. And so we used the model to help them think through this. And what they wanted to do was to sort of say, okay, well, look, we're sick of dealing with all these people who basically we tick off their claim anyway, which is about 95% of people. So what we're going to do is we're going to exception manage. So we're basically going to sort of say, okay, look, you come to the scheme, you get whatever you want. We'll look at people's claims history, and if they're above a certain threshold, then we'll go and investigate them and sort of see what's going on. We told them that was going to be a really bad idea based on the model. So we modeled this scenario. They knew about the model. We told them it was going to be a really bad idea. We said, everyone be really happy because you're getting rid of all the sand out of the gears of this system. It won't do, so your satisfaction will go through the roof. Your outcomes won't change because you already have a capped scheme for eligibility anyway. So people hit a threshold and they're out. So your outcomes, health outcomes, won't change much, but you'll lose a lot of money. Now, we haven't got a calibrated model, so we don't know how much, how many monopoly dollars you're going to lose, but you're going to lose a lot of money. They went, yeah, cool story. They did it anyway. The result was their satisfaction went to 8.6 out of 10 or something like that. You should never have an insurance system where like 8.6 out of 10 average satisfaction. The the outcomes didn't change, but what happened was like this sort of adaptive thing that Andrew was talking about before. All the service providers realized, because they were self-regulating before, they're like, we don't want to get involved in this insurance scheme because it's too hard. The administration is too hard, blah, blah. They had taken all of that regulatory inhibition or away from the system. So all these service providers started piling into the system. They lost about $4 billion in the first year. This is a scheme that had a like $4 billion was a lot of money for them. So that they had so much claim on the scheme that all their computers basically sort of shut down, and they didn't even know what invoices were coming in for things because there was just so much volume. So the environment around them, which wasn't really, which was outside their understanding of what would happen, adapted to them. So even when you have a model that they like, they co-designed, they're involved with, will they actually use it for decision making? It's questionable.
Yeah. Very nice.
Thank you. So we are very close to time. Jacob, is your question a quick one?
It's a follow-up question. I don't know if it'll be quick.
Should we try it and then we'll call it quits afterwards? Okay, let's go for it. Jacob, you're up, mate.
All right, thanks. Thank you for a very interesting presentation. Just to follow up on that, I mean, if I was running that company after that, I would have hired you in an instant to, make sure we don't make a mistake like that again. So I'm just curious, like, what happened and why isn't that type of thing happening?
I think it just goes to agent-based models in general. Like you've got systems that are run by, the actuaries are the gods in those systems. Actuary says something, that's true. Some nerd from the university comes along with a funny agent-based model. It's got no sort of sign-off from multiple layers of, it's got no history to it. It's got no, it's a novel thing. That's the level of trust that people have in that is just not. It just hasn't got the same weight, But we did, when we went back there were new managers, and they said, "Oh, we showed them what had happened." They said, "Who did you show this model to?" And we said, "All of you. You were all here." And they're like, "Oh yeah." So we did get another contract after that, but it wasn't $4 billion, I can tell you. It was more like half a person for 2 years. Yeah.
Excellent. Thank you. Well, thank you both for presenting to us today. We really do appreciate it. It's very interesting. Definitely see why you won the award. Perfectly blunt. So appreciate your time, and I will say thank you very much now. So thank you very much.